Hello, students. Welcome to chapter 21, kidney disease, part 3. And right now we're going to speak about chronic kidney disease and kidney stones. And the last part of this chapter is going to be dedicated to dialysis, okay? All types of dialysis. So, chronic kidney disease, the disease process is a progressive breakdown of kidney disease which impairs all kidney functions. New functioning nephrons remain and chronic kidney disease develops. Right now, we're going to mention chronic kidney disease as CKD. And this condition is going to develop slowly and no cure exists. So once your nephrons, your glomerulus start manifesting and they are not functioning, that's mean that the disease is progresses, right? So there is no regeneration like in liver. Approximately 15% of the US population has CKD. Individuals more than 60 years of age have the highest prevalence. And now so this condition is very common among people with metabolic diseases, with kidney involvement, especially diabetes, hypertension, cardiovascular disease, metabolic syndrome, right? Obesity. People with primary glomerular disease, the glomerular is inside of the nephrons, inherited disease, polycystic kidney disease, or congenital abnormality, and also other causes like immune conditions like lupus, obstructions such as kidney stones, chronic urinary tract infection, and long-term use of nephrotoxic medication. So here are a couple of definitions you can review. Modified risk factors include blood pressure, glycemic control, and addressing dyslipidemia. So they are telling you here that if you address and take control of your BP, blood pressure, your glucose, right, and the lipids, reducing sodium intake, and just double checking on your potassium levels, your phosphorus. It's basically a preventive activity that you need to go every year or every 6 months, depending on the condition you have, to get blood work done. So the doctor is going to be assessing how you are handling your blood pressure, your glucose, and everything else, right? So the another recommendation is to lose weight, to quit smoking, right? And right now we are reviewing. We know that there are 5 stages of kidney disease, right? And also just remember that stage 5 is the end stage, right? Okay, end stage renal failure, right? SRRD. Clinical symptoms: chronic kidney changes may involve extensive scarring of renal tissue, which distorts the kidney structure and causes vascular damage. Also, malnutrition, bone and mineral disorders like anemia and CVD will occur. Water balance: during the early stages of chronic kidney failure, the kidneys are unable to reabsorb water or to concentrate urine properly. This happens on the early stages. Therefore, the afflicted individual produces a large amount of dilute urine, which is polyuria, right? Dehydration is a risk factor for this point, and it may become critical. So as the disease progresses, the patient urine production will decline to a point of oliguria and then finally to anuria. Oliguria is less urine and anuria is going to be no urine at all. Okay, nitrogen retention: elevated blood urea nitrogen, your BUN, serum creatinine, and serum ASIC levels reflect the characteristic laboratory finding on azotemia. So for azotemia, you're going to have elevated BUN, elevated serum creatinine, and elevated serum uric acid, okay, for azotemia, and that's good to know. And this is NCLEX alert. So protein energy, that's good to know. NCLEX alert. Okay, So protein energy malnutrition is a common complication of protein catabolism. So there is a table here, stages of chronic kidney disease. You have in stage 1 the description. You see the glomerular filtration is going to be more than 90, and then in stage 2 the glomerular between 60 and 89. In stage 3, 30 to 59. In stage 4, 15 to 29. On the final stage, kidney failure, the one that needs dialysis, less than 15. Okay, so let's move. So at least you understand right now there are 5 stages, and basically what the doctor is going to check is the glomerular filtration rate. Okay, let's talk about electrolyte and mineral balance. So decreasing nephron function causes several imbalances among electrolytes. The nephron is going to cause the imbalances in electrolytes. The failing kidney cannot appropriately maintain the vital sodium and potassium balance that guards the body water. And remember, the sodium and potassium, they have an inverse relationship. So also the metabolism of nutrients producing a concentration of material, phosphate, sulfate, organic acid, and without a proper filtering. Remember we spoke about the different functions: filtering, reabsorption, excretion, right, and secretion. And without the appropriate filtering, these materials accumulate in the blood, thereby causing metabolic acidosis, the disturbed medication of calcium metabolism, the disturbed metabolism of calcium and phosphorus, which also has an inverse relationship, the abnormal levels of parathyroid hormones, and the lack of activated vitamin D, a process that occurs in the kidneys, lead to bone pain, abnormal bone metabolism, and chronic kidney disease, mineral and bone disorder, or osteodystrophy. So what is the meaning of osteodystrophy? It's going to be abnormal bone metabolism and chronic kidney disease, mineral and bone disorder, right? Okay, anemia, the damaged kidney cannot produce enough erythropoietin to accomplish its normal initiation of red blood cell production. Therefore, this is the participation of the kidney in the creation of RBCs, right? Therefore, there are fewer red blood cells produced, and those that are have a decreased survival time. Now, hypertension, when blood flow to the kidney tissues is increasingly impaired, renal hypertension develops. In turn, hypertension causes cardiovascular damage and the further deterioration of the nephron and also the epithelium problems. Now let's go to general signs and symptoms. We're going to see progressive kidney weakness. We are talking about chronic kidney disease, shortness of breath, fatigue, anemia, swelling in the extremities, and itchy skin rashes, anorexia, nausea, vomiting, the whole package, right? That's worsening nutrition and weight loss. Protein energy wasting syndrome is a common occurrence in patients with CKD. Okay, so malnutrition and weight loss, also protein energy wasting syndrome is a common occurrence in patients with CKD. Malnutrition lowers resistance to infection, okay, and those individuals, so we don't have enough protein in the body to build different soldiers to protect our immune system, right? So some individuals may experience bone and joint pain in advanced stages, irregular cyclic breathing, which is called Kussmaul breathing, indicates acidosis. and I have a video about that, but let me finish here. Acidosis may cause mouth ulcers, a foul taste, and bad breath. Nervous system involvement may involve muscular twitching and peripheral neuropathy. So let's watch discus mouth breathing. It's going to be like 30 seconds, I think, the video. Let's see. So you can identify, because you're going to receive patients like this on ER. This is a very sad situation. She's looking at a fixed point. Look, the jugular vein distension in the neck, because mouth breathing, right? Acidosis. Medical nutrition therapy for chronic kidney disease, individualized and adjusted according to the progression of the illness. And then this is the nutrition, has to be individualized and adjusted. And the whole purpose of this is to prevent malnutrition. Okay, principles. You don't have to memorize this, but just to understand why this is happening. The nutrition therapy for individuals with CKD who are not on dialysis, yet. Okay, so protein, the goal is to provide adequate protein to maintain tissue integrity while avoiding excess. Remember that in the next video, we're going to speak about the patients on dialysis. So this is not on dialysis. Enough protein, but also we have to avoid excess. Limit dietary protein intake to 0.6 to 0.8 grams per kilogram per day for those without diabetes and they are not on dialysis and who have a GFR or less than 30. Okay, so basically you're stage 4 kidney disease. And also recommends a protein intake of 0.8 to 0.9. That's a little bit higher. When diabetic nephropathy coexists with CKD, with chronic kidney disease, a protein intake of less than 0.8 may result in hypoalbuminemia. So may result in low concentration of albumin for these individuals. To encourage the use of plant-based proteins, this is very healthy. They also going to encourage the use of plant-based protein, so kind of vegetarian, and recommend that at least 2/3 of the individual's protein intake come from high-quality plant protein sources and or plant and animal combinations. Okay, essential, because the thing is to complete the essential amino acids profiles that are crucial. Okay, so this is a patient that is on stage 4 kidney disease, not still that is not in dialysis. Energy, carbohydrate and fat must provide sufficient non-protein calories to supply energy and spare protein for tissue synthesis. And then the recommended energy intake is 23 to 35 kilocalories per kilogram per day. Energy needs are lower for overweight individuals, okay, because they don't have to move too much body mass, with both CKD and diabetes to allow for weight loss, okay? And then remaining calories should support cardiovascular health. So overweight, they have less energy needs than obese, okay? So that's what you need to capture on this. Patients with CKD have accelerated cardiovascular disease, right? For individuals with diabetes, glycemic control is an important part of their nutrition intervention, and the recommendation is to achieve a A1C value of approximately 7%. Okay, and let's continue with this, right? Sodium and potassium, the general population recommendations for sodium is less than 2.3 grams per day, and potassium unapplicable until complications are present. So you are going to follow the regular recommendation until complications are present. If hypertension and edema are present, we have to limit the sodium intake. That's logical, right? To 2 grams per day. And less potassium is clear from the blood, right? As CKD advances to stage 3 and 4. Okay, now we have the phosphorus and calcium inverse relationship. Inappropriate blood phosphorus and calcium levels negatively affect bone composition. We know that. As the kidneys lose function, make sure you understand this, because when you come to the fourth semester in the musculoskeletal section, we're going to speak about a lot about calcium and phosphorus. They are no longer capable, as the kidneys lose function, they are not longer capable of activating vitamin D or controlling blood calcium levels. Now, moderate dietary phosphorus restriction depends on laboratory values, as it's generally limited to 800 to 1,000 milligrams per day when the serum phosphorus level is more than 4.6 or with an elevated parathyroid hormone level. So restriction of total elemental calcium intake to include dairy supplementation and calcium-based phosphorus binders is to no more than 2 grams per day in CKD stages 3 and 4. Okay. And then we have the recommendation for vitamins and minerals. This is a very important part. Avoiding supplemental fat-soluble vitamin A. And remember, your fat-soluble vitamins are your ADEC vitamins, right? Whereas your ADEC vitamins are your A, D, E, K, fat-soluble. Okay, you need to know that also. That's good to know. And then, so vitamin A and E, because they may accumulate to toxic levels in those with kidney failure, okay? Likewise, patients should avoid excess vitamin D and K. Remember, you're a DEC fat soluble, because the kidney cannot convert vitamin D to its active form. Remember that vitamin K somehow participates in the conversion from inactive form of vitamin D to the active form of vitamin D, okay? And surplus vitamin K can adversely affect clotting time. Okay, that's another thing that we must remember. Vitamin K, so you have to really conduct a very thorough assessment. Vitamin K can adversely clotting time, right? So you need to check who's the patient, what medication patient is taking, the patient taking warfarin or any other anticoagulant, right? The specific MNT recommendations are to help individuals meet their dietary intake for the B complex, vitamins, and C, and to determine the patient's specific needs for vitamin D and iron. Now, fluid intake should be sufficient to maintain adequate urine volume in patients who are not undergoing dialysis. The healthcare team will determine fluid restrictions based on medical factors such as edema, blood pressure control, and changes in urine output. So those are the three criteria that the doctor will use to see. And also you can use this at home with your family, right? Is my mother, my grandma having edema? How is the blood pressure? Are they urinating enough, right? So you have to consider all of that in order to provide indications, instructions for this fluid intake. So here you have a nice case study, right? And what I'm going to do is I'm going to skip the whole part about dialysis, because this deserves unique video, and I'm going to right now jump into the, let me see, kidney stones. Okay, kidney stones disease. So the etiology of nephrolithiasis, nephro refers to kidneys and lithiasis is a stone. You need to know this particular suffix and prefix, right? So the cause is unknown, but many factors that relate to the nature of the urine itself, the pH concentration, or to conditions of the urinary tract environment contribute to supersaturation and stone formation. So is the maybe the nutrition, maybe it's the pH, what's going on? Comorbidities such as obesity, diabetes, gout, and hyperparathyroid, remember, right? We were talking about the parathyroid when we are talking about phosphorus, right, and the calcium, and the status of the parathyroid increase the risk for stone formation. The most common type of kidney stones are number one, calcium, struvite, and uric acid, in that order, okay? And that's good to know. Disease process, calcium stones, the supersaturation of kidney stone material in the urine may result from the following. Okay, so it could be either, we are talking about calcium stones, right? Either excess calcium in the blood, right? Hypercalcemia, or urine, which would be hypercalciuria. Another factor is excess oxalate, hyperoxaluria, or uric acid in the urine, hypericosuriya, or low levels of citrate in the urine, hypocitraturia. Now, high levels of urinary oxalate increase the risk for an individual forming a calcium oxalate stone. What, professor? Can you repeat that, please? Yes, of course. High levels of urinary oxalate, right, increase the risk for of an individual forming a calcium oxalate stone. High oxalate foods resorts are dark green leafy vegetables, your spinach, your kale, your collard greens, now your beans, wax and dry beans, your beets, potatoes, brown products, cocoa, tea, and some nuts. High in oxalate. So that's why you need to drink a lot of water. If you are consuming these products, drink like 3 liters of water per day. Small percentages of the population are hyperabsorbers of dietary oxalate and thus are at the high risk of forming stones. Oxalic acid is a metabolite of ascorbic acid. Pay attention to this, very important, chin chin. Oxalic acid is a metabolite of ascorbic acid. Therefore, the long-term supplementation of vitamin C in excess of the tolerable upper intake, which is 2000, may possess a potential health risk for kidney stone formation, especially for women. So, adequate dietary calcium intake helps to prevent calcium oxalate stone formation. And so you can have the calcium oxalate, but you need to have the adequate amount, not the excess, okay? Individuals with a low dietary intake of calcium are at higher risk for calcium oxalate stone formation than those who consume the dietary for calcium, okay? Now here you have this nice picture about the renal calculi stones in the kidney, renal pelvis, and ureter. Look the stones in the medulla, the stones, the calcium oxalate jackstone type, okay? You have the renal pelvis, how the stones starts to collect over there, right? Risk factors for the development of kidney stones, you have the dietary, inadequate fluid intake. I would say this is the most important, right? You can have the regular dietary intake, and but you are not drinking enough water. I would say you're in high risk. So you need to drink water. Low calcium intake, right? High animal protein intake. So you're eating eggs and sausages in the morning. Then at your lunch, you're having like a nice piece of steak, right? A nice piece of steak or maybe chicken. And then at night, another huge piece of protein, right? Besides eggs. Now, high animal protein intake also. high sodium intake, frequent sugar sweetened beverage consumption, your sweet and low, your stevia, your Splenda, sweet and low, your Splenda, okay? You can have stevia, is better. And all these disorders are family history. Now let's talk about struvite stones. They are approximately 10% of the kidney stones and are composed of magnesium, ammonium, phosphate, and carbonate apatite. Okay. We frequently refer to them as infection stones. Okay, infection stones because they are primarily caused by urinary tract infections and not associated with any type of nutrient. Okay, struvite are not associated with any type of nutrient, but they are associated with infections. That's good to know. Ring ring. Okay, NCLEX alert. So when we are talking about kidney stones, we know that the calcium oxalate are related to the oxalate products, but the struvite are related to infections and not to nutrients. Wow. Then we have the uric acid stones. The primary risk factor for uric acid stone formation are overly acidic urine, excess urinary excretion of uric acid, and low urine volume. So you are urinating like 1 ounce every 10 hours. Oliguria, right? Hyperuricosuriia may result from an impairment of purine metabolism. Purine is a nitrogen product of protein metabolism and forms uric acid. So purine related to protein metabolism and forms uric acid. This impairment occurs with diseases such as gout, and you should be familiarized with gout at this point, and it can occur with rapid tissue breakdown uric wasting disease, right? Other conditions that are associated with persistently acidic urine and uric acid stone formation are diarrheal illness. You have your short gut syndrome, or inflammatory bowel disease that you're going to study with me in the fourth semester, type 2 diabetes in the fifth semester with Professor Taylor, obesity, and metabolic syndrome with me also. So these are your uric acid stones that are producing, wastes related to purine. Other stones, rare forms of kidney stones, are often reflective of hereditary disorders or complications of medications. For example, cystine stones are the result of a genetic defect in the renal reabsorption process of the amino acid cysteine, right? The oxidized dimer form of the amino acid cysteine. Or without reabsorption, cystine accumulates in the urine, cystinuria. Cysteine is not soluble, and thus a high concentration may result in stone formation. So clinical symptoms of kidney stones: severe pain, we know that, flank pain. Medical nutrition therapy for nephrolithiasis, regardless of the type, right? In terms of energy. Overweight and obesity increase the risk for several chronic diseases as well for kidney stone. So the recommended diet is the DASH diet, right? And the Mediterranean diet that are ideal. And providers should discourage high protein, low potassium diets for individuals at risk for stone formation. Excessive protein intake from animal sources is a risk factor for kidney stone. We know that. That's why they are suggesting the animal protein source. Thus, individuals should normalize their intake to healthy population standard recommendations. Calcium, low dietary calcium intake is a risk for calcium oxalate stone formation. Okay, that's the dietitian or healthcare provider should encourage the patient to meet the DRI, dietary recommendation intake for calcium, which is 1,000 to 1,200 milligrams per day, and balance intake throughout the day. Phosphorus. Okay, if patients are consuming phosphorus, remember the inverse relationship between calcium and phosphorus. So if the patient are taking more than 700 milligrams per day, that's a no-no. Sodium and potassium. High sodium intake increases the amount of calcium excretion in the urine. Let me repeat it again. High sodium intake increases the amount of calcium excretion in the urine, thereby precipitating hypercalciuria. That means calcium in the urine, right? And it is associated with an increased risk of stone formation. All stone formers should observe a low sodium diet, right? And citrate and potassium are helpful in solubilizing calcium salts and preventing calcium oxalate stone formation. Consuming a diet that is rich in fruits, for example, your citrus fruits and vegetables, helps provide a potassium intake of more than 4.7 grams per day. Interesting. Now let's move to oxalates. Um, Limiting dietary oxalate reduces urinary oxalate excretion and the risk of calcium oxalate stone formation. Now, individuals prone to calcium oxalate stones should avoid unnecessary intake of high oxalate foods. That's very important. Vitamin and minerals. Vitamin C should not exceed the DRI, and all other vitamin and minerals intake should meet the DRI standards. So you don't go to your favorite store to buy 1,000 milligrams of magnesium because you think so. You first go get your results from vitamins and minerals from your PCP. Then, based on that, you are going to request the doctor to prescribe you a safe dose of the mineral or vitamin that you need. Fluid, a large fluid intake of at least 2 to 3 liters per day, that's what I'm saying, helps to promote more dilute urine and thus to prevent the accumulation of materials that concentrate into stones, right? Exact fluid intake needs vary by individual, but healthcare providers should encourage enough fluids, preferably water, to produce at least 2 to 2.5 of clear urine daily. So then we are going to talk about the calcium stones. If a stone consists of calcium phosphate, the client can minimize unnecessary dietary sources of phosphorus because it's calcium phosphate. And the foods containing phosphorus and the additive like meat and legumes. So here is a very nice table, 21.5, summary of dietary principles in kidney and stone disease. I love tables, and I think this is a very good one. You have at the end the amount of fluids that you need to take, and in all types of the stone it says increase fluids, right? On the left side is the stone type. You have the calcium, the idiopathic or calcium oxalate, then you have the calcium phosphate, then you have the uric acid, cysteine, and struvite, right? That we know is related to infections, right? So in the case of calcium, very important facts that probably it can help you to study and differentiate. Let's look at sodium. In calcium oxalate, it says reduced to less than 2,000 milligrams. When it comes to calcium phosphate, is to reduce to 2,300, so it's a little bit better. And if you see the cysteine and struvite, it's the same criteria, reduced to 2,300. So right there you have 3 stones with the same recommendation. You don't have to memorize, right, specific crazy facts. And then when you go to animal protein, and that's another interesting part. In calcium oxalate, you have to reduce to 0.8 grams per kilogram. When it comes to calcium phosphate, less than 1.2, okay? Uric acid, there is no specific, it's like reduce also the purines, but in cysteine is going to give you the recommendation similar to calcium phosphate. Okay, and then those are the most special numbers. Then your calcium, 1000 to 1200 in terms of calcium oxalate. Then you have your calcium phosphate, 800 to 1200, right? And then your estruvite. All the other spots are empty, meaning that there is nothing to memorize or to understand. Let's move to uric acid stones. Dietary attempts to alter urinary pH with alkaline diet. Haha! These people using the alkaline diet. And what is the alkaline diet? Basically, don't eat meats, proteins, but you are going to eat a lot, right, of fruits and vegetables. That's your alkaline diet that most of the cancer patient uses. So dietary attempts to alter urinary pH with alkaline diet, because when you are acidic is when you are in more risk to have all type of conditions, including stones. So you want to be alkaline. That are low in purines may help to prevent uric acid concentration and stone formation within the kidneys. Acidic urine favors the kidney reuptake of uric acid, whereas alkaline urine favors the excretion of uric acid. And now the cystine stones, the following dietary modification help reduce cystine stone formation, reduce urinary cystine concentration by decreasing intake of animal foods high in cystine and methionine. Also, you have to reduce your sodium intake, increase intake of vegetables that are high in organic anions, and dilute your urine. In terms for exam for NCLEX, I will add here, that's good to know, in terms of the alkaline diet, because we want to go to the other side. We don't want to be in the acidic state, right? We want to be on the alkaline state. So here we are going to put it, that's good to know, referring to the alkaline diet. Okay, and then this is it for part 3. Okay, and then when we come back, we're going to check the dialysis in kidney, the end stage kidney failure dialysis. Okay, thank you so much for attention.